Alright guys, Mr. Merlin here, Mr. M, and today we're going to be doing cervical spine. So we're going to be doing the C-spine, and for the C-spine we're going to be doing apiaxial obliques, which is 2. We'll do the LPO, RPO. We're going to do the open mouth, AP open mouth, the odontoid. We're going to do a lateral. We're going to do lateral hyperextension and flexion, and then we'll do the swimmers. So we're going to be doing a total of 8 projections. Alright, so let's go ahead and get started with that. Okay? Alright, so we're going to go ahead and bring our patient in right now. So what we did was we gave him instructions to go ahead and remove everything above his waist. He has to remove necklaces, any jewelry, including earrings as well. We're also going to have you remove the glasses, if you can. And realistically, guys, in the field, we'll have him remove the lantern he's wearing, but he can keep that on right now. But you want to clear the whole area, including earrings around the head, because you're going to go ahead and turn the head. You're going to go ahead and do a lateral view. You don't want those inside, okay? So what we're going to have you do is we're going to have you stand right over here and put your back against the board, okay? And for the cervical spine, you can do it lying down or standing, but what we're going to do is standing here. All right. So I'm going to go ahead and raise this up, sir, right there. And the cervical, the AP cervical, it's an AP axial. The reason why you're doing an AP axial is because the intervertebral joint spaces are turned at an angle inferiorly. They're turned at an angle downward, and you're going to have to go upward into those joint spaces. So what we're going to do is an AP axial. We're going to do it at 40 inches SID, and then we're going to transition into the obliques from there, okay? So we have our receptor. We'll put this right here. Put this inside. Can't forget about our shielding. We're going to go ahead and take this off. Good Velcro. We're going to have you go ahead and wrap this around your waist. I'll meet you around the other side. Try to get the patients to help you and work with you. You don't want to go ahead and start wrapping your arms around him all crazy, right? So we got the shield on him. We're going to go ahead, and depending on your facility, I know there's a big debate about shielding right now, but in California here, we're still using gonadal shielding, so we'll still apply it. All right, so we're going to be using a 40-inch SID. All right, we're going to go right here just like this here. We're going to angle the two 15 degrees. So it's going to be 15 to 20 degrees. So if you have a perpendicular beam of 90 degrees and you add 15 degrees to that, it's going to be at 105. All right, so people look at it and say, oh, it's not 15 degrees, it's 105, but that's because you add 90, right? You add 15 to 90 degrees, it's going to be 105. Now, for the cervical spine, you're going to be centered right in the middle of the neck. Now, everybody's neck is different. Some are longer, some are, are thinner, some are wider, some are shorter. But you always put it in the middle of the neck. Keep that in mind. So your central ray location is going to be in the middle of the neck. That's a level of C4. So it's pretty much going right at the thyroid cartilage if you think about it here, right? So that's why you want to make sure that you don't have a lot of repeats because, again, the thyroid is a sensitive gland to radiation, correct? So keep in mind what your technical factors are. Technical factors for this procedure, for the AP axial C-spine, I use anywhere between 8 to 10 mass on the cervical spine at about 76 kV, 76, maybe 75 kV if that. But again, it's about 8 to 10 mass depending on the patient's thickness of the neck. If it's a more muscular patient and they have a lot of muscle and dense region around the neck, then I'll go ahead and go to even 12.5 mass sometimes, just depending on the patient's size and thickness. All right, so I'm gonna go ahead and put this here, right in the middle of the neck. Sir, I'm just gonna raise this up behind your head here. There we go. Okay. I have my markers here, so I'm going to go ahead and use my left marker here. Have my left marker. I'm going to put it on this side of the patient, right over here. Okay. I'm going to open up the width of my collimation, just about an inch on the sides, just enough to get my marker in there on that side here. All right. So I need to make sure that I'm detented. So sometimes this happens, and that's okay. But sir, I'm gonna have you relax and take a side step to your left. And you guys see that I'm not centered here? So I'm just gonna go ahead. There we go. And I'm gonna make sure that we're centered here. There we go. Okay. I felt something was wrong. There was a disturbance in the force here, right? So we're gonna have you put your back against the board here again. There we go. I'm gonna hit that light. So I'm gonna go ahead and just make sure you're centered here. I'm going to put my left marker. This is my left marker on the left side. I'm going to make sure he's centered just like this. I got just about an inch on the sides of the neck. Before, back in the days, we used to collimate just to the spine. but they changed the criteria. Now we're going to the soft tissue sides of the neck as well now. So I'm gonna open it up just past the chin. All right, so just past the chin. And remember, I got this centered here with my receptor. So you wanna make sure it's centered to C4, the middle of the neck. You wanna make sure that you're centered to the wall unit and your receptor. We got our left marker right here, you guys. I got my technical factors set. I have, for this gentleman here, I have about 8 mass at about 76 kV. If it was somebody my size, I'd use about 10 or maybe even 12.5 mass for my neck. But again, you want a high scale of contrast, right? It's bone work. If we're doing a soft tissue neck, then you would go ahead and apply the 15% rule and you go higher in kV and go down in mass, right? But this time we're doing it for the bone work. So this is gonna be your AP axial, all right? We got it all set up and we're done here, we're ready to go. And that's at a 40-inch SID. The textbook now suggests that we do our obliques at 60 to 72 inches, all right? Before, we used to do them at 40. The newer textbook suggests that we do 60 to 72 inches. So for this gentleman here, we can go ahead and bring it back to 72 inches. All right, I'm gonna make sure I don't get you in the eyes here. I'm gonna bring this down. We're gonna go to 72 inches here. Now, if your system doesn't allow you to do so, you might hit the table. So you might have to go ahead and do a 40-inch SID. So only if your equipment accommodates the distance of the SID of 72 inches, then you can do so. On our system, it does. So we can go ahead and bring it back to 72 inches. All right, just like that. Now, what we're gonna do is, we're gonna go ahead and turn into an RPO position here. So this is a right posterior oblique position. All right. I'm gonna put my right marker here. Here's my right marker. I'm gonna put that right over here. Okay. So now, let's do that here. I'm gonna open up the collimation widthwise a little bit. That's lengthwise, let's go widthwise right there. Now, I'm gonna have him come forward here. Now, I don't know if you can go ahead and come closer here to see the shadow. Let's see the shadow of what I see over here. So he's at a 45-degree angle. Do you see the shadow right here? I want it to try to get it in the middle of that light field here. So I'm gonna open this up just a little bit wider, just a little bit. Can you see that shadow right here? That shadow? You wanna make sure that you're not cutting off the vertebral prominence in the back, right there, there we go. So we're at 45 degrees. We're using an angle of 15 degrees because now what we're doing is we're going into the intervertebral joint spaces. So this is a right posterior oblique and we're gonna be seeing the left intervertebral joint spaces. So we're seeing the elevated side. All right, so that's what gets people all the time. So we're doing an RPO to see the left intervertebral joint spaces. So that's the upside, that's the side away from the IR, okay? Again, technical factors for this would be about 10 mass at about 78 kV. All right, so we make that exposure, then we're done. So now we're gonna go ahead and rotate the other way, just like this. And again, you can see the shadow. You can see that shadow. Do you see that shadow back here? I want that shadow in the middle. All right, you guys see that shadow? So now I'm gonna put my left marker over here. So I got my left marker, I'm gonna put that right over here. He's at 45 degrees, okay? All right, we want that line right in the middle. It's still gonna be at the level of C4. So now we're doing a left posterior oblique. This is a left posterior oblique, this is an LPO. Now we're gonna see the right intervertebral joint spaces. So again, it's the elevated side, it's the side away from the IR. Again, it's the upside, okay? So this would be our AP axial and then AP axial obliques, all right? So now we're gonna go ahead and do the odontoid. So we're gonna do the open mouth projection. I keep the left marker here. We're gonna go back to perpendicular, and you can go in any order, you guys. You can really go in any order. So now we're gonna bring this back to 40 inches. Some people start with the open mouth and then they do the AP axial because you're already at 40 inches. All right, so it doesn't really matter. I guess depends on how fast you can do them. So now we're gonna be doing what's called an open mouth projection. It's known as the odontoid because you're gonna have the patient open the mouth. you're gonna go through the mouth to get to the vertebrae on the back end portion of the body. So here, you guys, I got the left marker over here. I'm just gonna raise this up behind your head here, so make sure that we don't hurt you. All right, my field is about 4 by 4. So just go under the nose and about where the mentum here is the chin. And then we're gonna go ahead and go to the width of the mouth on the sides. I don't know if you guys can see that here. So now what I'm gonna have you do is just kind of tilt your chin down a little bit. There we go. All right, so I'm looking, you guys, I'm looking at the face, and when he opens his mouth, you wanna make sure that the lower margin of the upper incisors, the bottom of your top teeth, all right, are gonna be parallel to the floor. Now, I've done thousands of these, you guys, and once you do one, you screw a couple things up, you're gonna figure out how to fix it, right? So this one here is called the odontoid. It's the open mouth projection. You want the lower margin of the upper incisors aligned with the base of the skull, okay? This is gonna be the back here, the mastoid process. All right, your patients can turn on the column mirrors too, right? So, all right, so now you guys, we're gonna have him open his mouth as wide as you can. Ah, there you go, just like that. I'm gonna tilt your head down a little bit, right there. Okay, so now his head's straight. I'm in the mid portion of the mouth. All right, so what you can do is go ahead and go ah, ah, and when he does that, you make the exposure. Again, have your technical factors set prior to coming over here and doing this. Don't be having the patient with their mouth open while you're fiddling with the technique, right? You can relax. All right, so now, if he tilts his head too far back, there's excessive extension. And what's gonna happen is the occipital bone is gonna come back and it's gonna superimpose over the dents. If his head was too far down, there's excessive flexion and his teeth will superimpose over the dents. All right, so again, by evaluating your image, you can tell whether you have too much extension or too much flexion. All right, you wanna have it just right, just like Goldilocks, right? Again, this is one that's gonna take a lot of practice, but again, it can be done. All right, so we've done the apiaxial. We did the 2 apiaxial obliques. We're gonna go ahead and kick it back to 72 inches. Really quick here. All right. And we're gonna do a lateral. All right, so I got a little OCD, there we go. Ah, all right, there we go. Okay, so now we're gonna be doing a lateral of the C-spine. So standard is a left lateral, but you can do either one, but normally we do a left lateral. So again, you're gonna wanna have it centered at C4, which is the middle of the neck here. All right, so I got this centered here. I'm gonna go ahead and I'm gonna collimate down just a little bit here, just to make sure that I'm not overexposing him. I want the shadow that's right here, I want it in the middle. I want him to relax his shoulders as much as possible without moving. There we go, try to keep your shoulder right there so you have some stability. I have my left marker here. Let's see, there's left. I'm gonna place it right over here on the left side. All right, so standard technique for the lateral is gonna be about 12.5 at about maybe 74, 76 kV. All right, so again, you know, the bigger the person, you're gonna have to maybe increase your technical factors. If they got a lot of mass around the neck, sometimes I've gone up to maybe, 25, 30 mass, depending on if they're like a football player, bodybuilder, they got a lot of muscle there, you're gonna have to go through that. So again, about 12.5, 10 mass at about 76, 78 kV, and this is your lateral C-spine. But guess what? You want him to relax your shoulders, so how do we do that? We have the patient breathe in, and you're gonna let it out, and when he does that, his shoulders are depressed, and that's when you make the exposure. Okay, you can relax. Now, only if you can, you're gonna be doing what's called hyperextension and flexion. So hyperextension, you guys, and flexion, you're gonna be bending your neck. So if he tilts his head all the way back here, that's gonna be hyperextension. So this is done for range of motion, mobility, for you're looking at intersegmental joint spaces. You're looking for stability of the neck. All right, so again, I'm gonna push him forward just a little bit right there. All right, so go ahead and breathe in, let it out, and take the x-ray. Beep. Okay, you go ahead and breathe, relax. Now we're gonna have you tuck your chin down inward. So now we're gonna be doing what's called hyperflexion or flexion. I'm gonna open this up wider because I don't want to cut it off, and then here's my left marker again. All right, the field's gonna look a little bit larger, but that's okay because I do not want to cut off this right here, which is called your vertebral prominence. That's C7. And I don't want to cut off the anterior portion of the cervical spine here. Maybe I can come down just a little bit right there and have them go forward, but that's about it because I don't want to cut anything off. So this is going to be your hyperflexion, And again, this is done for stability, range of motion. You can relax. If you had a surgical spine surgery, they're looking at range of motion, especially when they do fusions. They do these procedures here, and for whiplash. Now, if the patient had some type of cervical collar on, you can shoot through these collars. They're made out of thin plastic and foam. If they come on a backboard, they have straps on. You can take the x-rays through the cervical collar. Just add about maybe 4 kV to go through the collar, okay? All right, so now we're gonna do our last one, and we're gonna do what's called a swimmers. Now, a swimmers is for the cervical thoracic region. All right, I'm trying to look for my left marker here. Here we go. So, the cervical thoracic region is a swimmers. So, that's gonna be for an area where it cannot see C7T1. All right, so we're gonna go to 40 inches right here, just like this, 40 inches. All right, okay, oh, I'm at 30 now. Oh, I got 40. All right, so, all right, so I try to feel it instead of try to look. All right, so now we're gonna open this up here, just below the earlobe now, because we don't care about the whole cervical spine. You're just trying to get C7T1 joint space. So what I'm going to do is I'm going to put it right on the vertebral prominence, right here. Now, I'm going to lower this here, sir. Watch your shoulder. Okay. So notice we're not getting the whole cervical spine. We're just going to go ahead and focus on the lower portion of the C-spine and the upper portion of his thoracic. So normally, this probably wouldn't be done on this gentleman here, but I just want to do it for demonstration purposes. All right, I'm gonna go ahead and get this centered right there. There we go. All right, so again, I'm looking at the shadow. I'm gonna go ahead and I'm gonna get my left marker here. Okay, I got my left marker. I'm gonna put it right over here in that area where there's light. Now, the arm closest to the IR, that arm's gonna go up. So go ahead, and he's never done this before, you guys, before. We're gonna put this arm up here. This arm you're gonna relax and just bring it back a little bit. All right, this is called a swimmers, like they're swimming. And this is for the cervical thoracic region. This is for C7T1 joint space, all right? So now I'm gonna go ahead and have him breathe in. I got the technique set. I got about 12.5, about 15 mass, sometimes when they're bigger, about 78 kV, because you wanna penetrate through that region. You're gonna have him breathe in, and then you're gonna have him breathe out, all right? And then I'm gonna go ahead and make the x-ray. All right, so I'm gonna make the x-ray on exposure, beep. Some techs have used a breathing technique on this one, where they do shallow breathing, and that can be utilized as well, about 3 seconds, right? And they have the patient breathe in, breathe out, breathe in, breathe out, and they're making the exposure as they're doing this. But this is called your cervical thoracic exam. This is your swimmers. This can be used for cervical spine and can be used for T-spine as well, thoracic spine. Now, if he cannot bring his shoulders down, we can shoot downward and use a 5-degree caudal angle. If the shoulders cannot be separated and depressed, then we can do a 5-degree caudal angle to get inside that joint space right here, okay? So that's only if you can't do this. But that's your cervical spine exams. The laterals are gonna show your spinous processes and profile, and you're gonna see the Z joints of C3 through C7. All right, again, we said the AP axial is done, you can relax it. The AP axial is done at a 15 to 20 degree angle because you're going into the joint spaces that are downward. Those are the intervertebral joint spaces. We said for the obliques, when you do an RPO, you see the left side. When you do an LPO, you see the right side. When we did our open mouth, it is done to demonstrate the odontoid and the Z joints of C1, C2. We then transitioned into our lateral. The lateral, you're gonna see all your vertebrae from C1 to C7. You're gonna see the spinous processes and profile, and you're gonna see the Z joints of C3 through C7. We did the hyperextension and the flexion, that's for whiplash. And then we did the swimmers to demonstrate C7T1. All right, so today I just want to tell you guys exactly what you're seeing in all these exams. Again, study your textbooks, write it out 10 times, look to see the structure shown of what you're trying to identify in the radiographic image. I'm hoping this is going to help you. We'll do some videos also on how to critique the images, okay? We'll get those done for you, right? Okay. Hello everyone, you guys. Thank you very much for watching the videos. I'm hoping that they're helping you out. Please make sure that you subscribe and that you hit the notification bell to be notified about new videos. Again, remember to be good to yourself and be good to others. Thank you.